Welcome to Brookings. My name is Ron Haskins. I'm the co-director along with Richard Reeves of our Center on Children and Family. We study kids, obviously, and we're especially interested in poverty issues and issues of economic mobility. And along with my CCF colleague, Belle Sawhill, I'm also an editor of The Future Children, which we publish twice a year with our colleagues from Princeton. Sarah McClanahan is the editor-in-chief, and the managing editor, Jonathan Wallace, is here in the audience today. Jonathan, thank you for coming. He's here primarily to keep an eye on us, I think. Whenever we release a volume, which we do twice a year, we write a 3,000-word policy brief about some issue that's covered in the volume, and we try to pick an issue that's related to public policy. And then we have a public event at Brookings and announce the release of the volume. We give an overview of the volume and so forth. So that's our purpose here today. Thank you all very much for coming. Here is the plan that we're going to follow for the event today. First, after I get through, Janet Curry, who is one of the senior editors of the journal and also one of the two editors of this volume. And she's also the Henry Putnam Professor of Economics and Public Affairs and the Director of Center for Health and Well-Being. I'm not sure she sleeps, but she does all that stuff at Princeton in the Woodrow Wilson School of Public and International Affairs. Then when she gets through, I'm going to give a brief description of the policy brief and tell you what the argument of the policy brief is. And our event is organized around the policy brief rather than the entire journal. The only time we'll talk about the entire journal is right in the beginning. It'll come up from time to time in the discussion, I believe. Then after that, we're very fortunate to have Debra Lubar here from the administration, from the Centers for Disease Control and Prevention. And she is going to talk about the administration's proposal on the Zika virus, which we'll get into in a few minutes. And then we're all going to sit down and we'll be joined on a panel. So we have a panel of 4 people discuss several issues that have come up, and then we'll give each of you a chance to ask questions of the panel. And Alan Barreca is here from Tulane, who will also participate in the panel discussion. So that's our plan. I hope you like it. Let's have a good time. Janet.
Okay, thank you very much, Ron. So this volume, starting point is the idea that the debate about climate change is often framed around effects on our children, but we're not generally very specific about what those effects might be. So the aim of this volume is really to get more specific about what the effects of climate change are likely to be on children. So there's 4 broad themes that come out of the various chapters. One important theme is that this is no longer something which we're speculating about. This is something that's already happening and will continue to happen. And it is going to and is already affecting children's health and well-being. Children are likely, for various reasons, to bear a disproportionate share of the brunt of climate change. Poor children, children in developing countries, and especially children in countries that don't have very strong institutions, are particularly at risk. And although we know that this is already happening and will continue to happen, we still have a lot of uncertainty about exactly how bad it's going to be. That depends in part on what we do. And the fact that there is this uncertainty, and also that the costs and the benefits are in the future, and also that they're going to be very unevenly distributed, I think make the politics surrounding climate change particularly difficult. So I'm going to start off just with this article, which many of you may have seen. It appeared in the New York Times yesterday, and I thought it was perfect for this presentation because it hits all the themes that I just talked about. Climate change is already happening. As you can see here in the United States, we have our first climate refugees who are being moved off of Ile de Jean Charles, which has lost 90% of its landmass and most of its trees because of salt coming up through the water table. And so 48 million has been allocated to move people off of the island to a different location. You can see that literally the poster child of the article is a 3-year-old girl whose family is going to have to move. This is a poor community. It's a Native American community, illustrating again that it's the poor who are most likely to suffer. And then on the political front, even this sort of relatively small and well-defined thing, let's take these people who are on this sinking island and move them somewhere else, is still kind of a heavy lift and fraught with various difficulties that are discussed further in the newspaper article. So in terms of what this volume covers, we start by talking about the science of climate change, what is known, what is not known. Having set the stage, we then focus on temperature extremes, which are one of the most obvious implications of climate change. Children are particularly vulnerable to health effects of high temperature, which is one of the many ways in which climate change affects children. We talk about climate change and conflict. There's a growing body of evidence that high temperatures are related to conflict, in part because they can have severe economic effects. So in parts of the world that are prone to conflict anyway, if you do things that threaten farmers' livelihoods, that makes it more likely that there will be armed conflict. We discuss natural disasters and effects on children. Again, that's one of the things that's expected to become more common due to climate change. We talk about pollution and climate change, which I'll go into a little bit more detail about in a minute. Climate change in developing countries, which is a particular problem. And then we talk, it's a little bit more technical chapter, but just about how do we measure the costs and benefits of climate change. A lot of the standard ways that economists think about things are quite difficult to apply when you have something that is going to take place a long time in the future, and also where there's substantial uncertainty. And that, I think, bedevils efforts to talk about this in a really rational way. And then finally, we come back to the political problem that it's so difficult to mobilize effort to combat climate change. Okay, so looking at temperature, this figure, which is from the chapter on temperature, shows the number of days over 90 degrees that are expected in 4 U.S. cities. The white bar is for 2001, 2010, so that's already happened. Then the next gray bar is 2046 to 2055, and the black bar is the end of the century, 2090 to 2099. See? So what you can see is that it's going to get even hotter in Houston, although it's pretty hot in Houston already in the summer, so maybe, arguably, people in Houston are used to dealing with that. If you look at Kansas City and New York, the two middle sets of bars, you have really big increase in expected hot days. So in New York, it goes from 10 days in the summer to 70 days in the summer by the end of the century, so that's a big change. And then Seattle comes off relatively easily with an increase to only 20 days of really hot weather. So this is just illustrating how the costs of climate change, even within the U.S., are going to be unequally distributed across regions. Now, some of the things that we could do about climate change in the short term, which will also have some benefits in the short term, are reducing pollution by, for example, switching more to renewables from fossil fuels. So this table here, which is based on the projection made by the Intergovernmental Panel on Climate Change, it's the projection A1B, for those of you who follow these things, is based on the idea that we use more renewables. And if you just look at the far right column of the table, there's an estimate of how much the switch to renewables would reduce infant mortality by reducing particulate matter. So this would be a benefit of something that would affect climate change in the longer run, but would have a short-term benefit on pollution. And you can see that these benefits are also unevenly distributed. So in the southeast, you would get almost a 20% increase or decrease in infant mortality. In the northeast, you would also have a fairly large decrease. In the west, not so much. Okay, so again, this figure is just summarizing what's in that column, showing the decreases in infant mortality that are projected by region compared to doing nothing, which is the light gray bars. Similarly, if you infant mortality is obviously very important, but one reason why it's important is because it's a more general marker for child health. So the same things that reduce infant mortality are expected to improve people's health in the longer term. Healthier people will have higher earnings, and so this projection is suggesting that earnings would also increase in the same places that had the biggest decreases in infant mortality. Now, moving a little bit from the US to the rest of the world, this figure is just showing particulates for one US city, Pittsburgh, where we have data over a long period of time. And we all know that the air used to be really bad in Pittsburgh, but it has really improved over time. And showing, by way of comparison, numbers for the same particulate matter pollution for Mexico and for China. So what you can see is that things have also been improving in China, actually, but they started at a much higher level, so people were being exposed to really bad air. And so, again, anything that affects pollution and also affects climate change would be a win-win in that it would have both short-run and long-run effects on people's health. Staying with the developing countries area, I mentioned a little bit about the research on conflict. This map is showing the Horn of Africa, which is a place that has a lot of conflict. And on the left, what you see is a map showing how much change in temperature there's been since 1991 to 2005, 2009. So you can see that even within that relatively small area, there's some places that are having much more temperature change than other places. And then using that kind of variation, the authors of this study, which is summarized in that chapter on conflict, shows that you would expect to have both a short-run and a longer-term increase in conflict as a result of the temperature change. So turning again, this is a kind of rapid walk through the volume, but turning to the chapter on costs and benefits, this table illustrates one of the problems. And so what it's actually showing is the solid line being a projection of economic growth, not paying any attention to climate change. So standard economic models that forecast economic growth don't usually take climate change into effect. Okay? And so we think that growth continues, and so in the future we should all be richer. Now the dashed line is showing what happens if you have catastrophic climate change. And I think the interesting thing about the dashed line is that nothing happens immediately. It's happening at the end of the century, and then you have a decline in real consumption compared to business as usual. Okay, so this is one of the things that makes climate change a heavy lift, in the sense that if we do nothing today, nothing will happen tomorrow. It'll happen in the future. And then another issue with respect to thinking about costs and benefits is the issue of what discount rate we should use for the future. That is, how much should we value things that are going to happen in the future relative to today? And again, if you look at the numbers on the far right, that's showing a 5% discount rate, which is fairly standard. And what that says is, well, we don't value at all $1,000 in 2,200, okay, because that's too far in the future for us to care about. Okay, so in order to have a discussion of climate change, we have to also change the way that we evaluate future costs versus benefits in order to take account of the needs of future generations. Okay, so I just wanted to make one comment about the heavy lift, to talk about one particular example, the Waxman Markey bill of 2009, which was not passed. So 2009, that's only 7 years ago. It already seems like a long time ago. If it had been passed, it would have reduced carbon emissions by 83% by 2050. Right? So that would have made a really significant impact on what's going to happen in the future. Now, of course, it wasn't passed. It did, after going through the House, it didn't make it through the Senate. And so this is just one illustration of sort of a history of failure to address the issue. So that's all I have time for. If you'd like to take a look at the issue, I think you can get copies at the back, or it's all online at this website.
Thank you, Janet. Appreciate it. As I said before, whenever we publish a volume twice a year, we write a 3,000-word policy brief trying to seize upon some issue that is implied in the volume, but to play it out a little bit, especially in a policy sense, and we try to pick things that are actively under consideration in Washington, and we were quite fortunate this time that Zika appeared. It's unfortunate for people's health. We don't know the extent yet, but it certainly does lend gravity to this event and to the issue, and it makes our point, which is there are a lot of implications here for public policy, especially for children's health, and so we'll learn a lot more about Zika in a few moments. So here's the logic of the brief. Temperatures are rising. Janet already covered things. I'm going to mention a few more things that I think are quite interesting. Rising temperatures have impacts on children's health. There's a whole chapter in the volume that goes into that in some detail, both direct and indirect effects. And one of the indirect paths is through infectious illnesses, which a lot of people might not think of as being related to environment, but I'll show you how that's the case. And Zika is a great example of that, and I'll talk about why. And we will, in doing so, we will focus a lot of attention on the Aedes aegypti mosquito, which is a strange little creature that has all kinds of habits that make it unlike other mosquitoes, and some of those habits bear on its vector, as the public health officials call the method of transmission, or the means of transmission. And then we're fortunate to have Debra here to talk about the administration proposal, and then, as is good in Washington, we'll have an argument about the proposal. So I just want to show two things about temperature. This is temperature, a graph from the National Oceanic and Atmospheric Administration, and it shows the temperature. If you look at it carefully, I think that statistically the trend line actually begins in 1950, but it looks like it really starts picking up around 1980, which is consistent with other evidence, and it has gone way up. And the last 2 years have been huge temperatures. I think 2015 was the hottest year we ever had. And we're on course in 2016 maybe to repeat that. So temperatures are going up, and especially, this is an important point, this is a kind of a difficult draft. I know we undoubtedly have great experts out here who understand this stuff very well, but for a normal person, what has happened, the red is temperatures, and the white is a normal distribution. And what is happening is that the temperatures are shifting up. The entire distribution of temperatures have shifted up. And an especially important feature of that is that the tails of the distribution, especially the positive tail, is increasing even more. So we're getting even more increases in extremely hot days, usually defined as 90 degrees or more, often defined as 90 degrees or more. And those are the ones that Janet pointed out and has pointed out in the volume that can really have big impacts on health, especially on infants. The chapter on the effects of infants shows that infant death even rises at temperatures above approximately 90 degrees. So if the projections are correct, these are really important considerations. So temperature is going up. And it has impact on children. It has direct impacts, as I've implied, on mortality, on illness, on infant deaths, and it has indirect effects, especially in vector-borne diseases, and these are laid out in greater detail in the chapter. But I want to focus on the vector-borne diseases, and the vector here is Aedes aegypti. So Martin Edwards, a famous entomologist, said of this little mosquito, he loves us. It loves our cities. It loves our blood. It's kind of a colorful statement about what this little guy is like. I mean, all mosquitoes to some extent love our blood, but this guy is especially thirsty. This particular mosquito carries a lot of infectious diseases, including yellow fever, dengue fever. I've read several arguments about how you pronounce this word, but I'm going to say it with an English American way of saying it, chikungunya. There's a more fancier way to say it, but I couldn't master it. So it really carries all of those in addition to the Zika. So this guy is a very important means of transmission of disease to children. And why is that the case? And why are we concerned especially about both Zika and the role of the Aedes aegypti? Well, first of all, there's some evidence that it has the widest range now that it's ever had. Places that have increasing temperatures, many mosquitoes are more likely. It's easier for them to breed. They multiply faster, and so they occupy new areas. There are predictions. I think these are mentioned in the journal, but not. There's several journal articles and other journals more focused on climate and children that say that even in the United States, we're going to start getting Zika, quite a bit of expansion of territory. It's present now in the southeast, but it will expand. It breeds in and around standing water, which is extremely important because especially when it's hot, people like to have more water, and especially in more traditional societies, they keep it in buckets and pails and all sorts of things all around, and any of that can be a breeding ground for Zika, as well as other mosquitoes. So that's an important idea that might have an impact and has in the past on trying to control mosquitoes and especially Zika, that you need to do something about standing water. Also, rising temperature allows the Zika virus to multiply more quickly in the Aedes gut. And there's a particular feature of this mosquito that I found fascinating. I didn't know anything about this until I started reading into this. Most mosquitoes bite you and suck up your blood, and they go away and they don't bite another person. They were satisfied for a while, and some mosquitoes, I think they only do it a couple times. But this mosquito takes only a little bit of blood, goes to the next victim, takes a little bit of blood, goes to the next victim, takes a little bit of blood. So they can infect several people if they happen to be carrying whatever they happen to be carrying. So this Aedes aegypti is really a formidable weapon in nature's attempt to get us. And it's after our blood, and it has the capacity to infect many people at one time. And that is why Margaret Chan, who's the head of the World Health Organization, in discussing the Zika virus, she said that it's the main cause of what she called explosive spread in the Americas. I'm sure she was referring primarily to South America. So this, of course, raises a question, now what? What are we going to do? It's not an emergency at this moment in the United States, but it's potentially a very serious problem. So should we do something? And here to answer that question is Debra Lubar from the Centers for Disease Control and Prevention. Debra, thank you so much for coming.
Thank you, Ron. I'm glad to be here, and I'm glad you set up our nemesis so well in this fight by describing the, do I need your pen? By describing the Aedes aegypti in some detail. I'm going to tell you a little bit about CDC and what we are doing and what we need to do, and give a little bit of background about the Zika outbreak. So just a little bit about this great agency that I represent. CDC was founded in 1946, and we were actually founded to deal with malaria. So mosquitoes are sort of part of our origin story and continue to be part of the work that we do. We're in Atlanta, so I got to fly in to see you all today. We're the only, I think, federal agency headquartered outside of Washington, which gives us a different perspective on life than many of you probably have. So our mission is to save lives and protect Americans from health, safety, and security threats. And one of the really interesting things about this outbreak has been seeing all of the expertise at CDC that we're able to draw on. So a lot of times when we're responding to emergencies, it's an infectious disease outbreak, and it's our infectious disease doctors and experts who are leading the outbreak. In this case, we've really seen across the agency, drawing on expertise in vector-borne disease, in environmental health, in birth defects, in reproductive health. And I think that we're a very unusual collection of people who are able to bring all of that together to support this response. So we base our actions in science, but we are very much a practical agency who's out in the field, and you'll hear more about that. We work in partnership with state and local public health agencies. So there's a public health system in this country, and CDC is not in charge of it. So that's sort of an interesting thing about our work. A lot of the authorities for public health interventions and things like that are local and state controlled. And so I'm going to talk a bit about CDC's budget because a lot of what we do is fund and support the public health system in this country and around the world. We're all over the United States, even though we're headquartered in Atlanta. So this gives you a little bit of a sense of where we are. We have some very specialized labs around the country, and one of them that you'll hear a lot about today is in San Juan, Puerto Rico, where we do our work on dengue and increasingly on Zika. We have over 1,600 people located in 60 countries. This will give you I'm just going to go through this really quickly. We're working on disease detection in general, on polio eradication and measles immunizations, flu, still working on malaria all these years later. Global HIV and AIDS is a huge part of our global footprint. We're training the public health workforce in partnership with other nations, and we're working on a cross-governmental initiative called the Global Health Security Initiative, which I'll mention a little bit more later. CDC's budget is really complicated, and my job, which I should have mentioned, is running the Office of Appropriations. So I work with Congress and the White House on CDC's budget, which is why I'm here today to talk to you about the Zika request. But CDC is funded from many different sources, and this gives you a pretty big picture of what our money does and where it comes from, and I can answer questions about that if people want to dive in deeper. The amount of our core budget is about $7 billion that Congress decides on each year. This is a budget history of that core budget, and you can see it's 2013 was low. You guys remember 2013 in DC. We had some sequestration and things like that. But relatively steady over the last few years. We are funded in these kind of broad categories that you can see on the screen. But something that people don't really know or understand about CDC's budget is how detailed it is. So you're not supposed to be able to read this. This is one page out of probably a 5-page table where 160-ish different budget line items are presented as Congress directs us to spend it. So we interact a lot with Congress about where our funding goes, and we are bound by that, which is one of the reasons that when we have emergencies and a need to surge, it can be challenging for the agency financially, and we're not always able to be as nimble as we would like. So just as one example that's relevant here, this is a budget history on vector-borne diseases. We do have a budget line item for that. The name has changed a little bit over the years, and you can see there was some growth there. You all may remember the West Nile virus outbreaks of the early 2000s, and there was some attention to vector-borne diseases in the United States. It's been kind of relatively steady since then. since that drop in 2007. But that's a place where Congress says this is how much money, you will spend this much and only this much on vector-borne diseases, and we get that direction every year. So Zika comes along, and this is an overview of the transmission patterns. And until the last few months, we actually didn't know about 2 of these transmission patterns, so or transmission pathways. And so this is really a space where we're learning more every day. We're more and more alarmed by some of what we're learning, and we expect to continue to find new, hopefully new solutions and also new challenges with this virus. So the sexual transmission pathway and the pathway to the fetus are the new findings. So just an overview, this is a flavivirus, which is related to other viruses, as Ron explained, dengue, yellow fever, and West Nile. It's primarily spread through the bite of infected Aedes species mosquitoes, and primarily we think through Aedes aegypti, but maybe not exclusively. This virus is not new. It was discovered in 1947, and for 57 years there were a whopping 13 cases reported. So very surprising. There was an outbreak in Yap in 2007, but very surprising at the end of last year when we started to see a huge spike in cases in Brazil. And the authorities in Brazil suspect that there were nearly 1 million cases. So that is tremendous, tremendous growth and not what we expected. The other thing that we didn't expect was this significant risk to pregnant women. So the efforts that you'll hear about, Zika is not a very serious disease for most people. Some people never know they have it. Other people have sort of general symptoms that might look like any other viral infection that we would all, sort of live with and get over. But the really tragic outcomes have been for pregnant women. And this is the first time in more than 50 years that we've discovered an infectious disease cause of birth defects. It's really the first time that a mosquito bite could cause these kind of lifetime consequences for families. There's also been noted an association with Guillain-Barré. Zika virus infection during pregnancy, we have now determined is a cause of microcephaly and other severe fetal brain defects. And what we don't know is the full range of health problems that might result from this infection to the fetus. And that's something we really do need to study. It's going to take time to see how children who may have been exposed develop. And that's part of the work that we're starting now and that we hope to continue with some emergency funding. So this is what we've been doing, what we've been able to do to date. We have determined the link with microcephaly. We're examining the link with Guillain-Barré. We're looking at a range of other adverse pregnancy outcomes. We have seen miscarriage and other things associated with Zika. We've learned that sexual transmission is more common than expected. It was sort of theoretically known, but it seems to be happening more than we would have predicted. And there's a lot more to be learned. So here are some of the things that we're doing. I hope you all have heard about our travel guidance, particularly for pregnant women. We're working with clinicians so that they know what to do with someone in the United States who may have traveled. I do want to say, I think Ron said this is not an emergency yet in the United States. This is an emergency in Puerto Rico right now and the territories. And so a lot of our early response has been to support those areas. And I'll talk a little bit more about that. We've been doing a lot in the laboratory diagnostic area, something that had 13 reported cases in 57 years. Most labs were not testing for. So we have several different tests that we have been getting out to the public health labs around the country. Again, that system where it's not all CDC doing the testing, although we do a lot of validation. And we have been developing new diagnostics that are easier to use, better at detecting. So this is a picture of our foe that you've described well. And I want to talk a little bit about the factors that contribute to spread. So we've heard a lot this morning about climate change, and certainly vector-borne disease and being able to track where vectors are and where vector-borne diseases are happening are an important part of understanding changes in the climate. What we've seen, though, is with this, it's not easy to determine what role climate might be playing. There are a number of other factors that are affecting the spread of this disease, including global travel and the movement of infected humans. We have over 400 Zika infections in the continental U.S., excluding Puerto Rico, and those are primarily travelers, some sexual transmission. But that's happening all over the globe. Living conditions, I'll talk a little bit more about, are a very big factor, as Ron described in terms of standing water and urbanization. The disease reaching populations who haven't been exposed before can cause these large outbreaks as well. And there may be changes in the virus, so we're still studying that. So this could be our public health intervention if we could just get the mosquitoes to avoid us and go to happy hour. That would be most excellent outcome. But that's not available, so we are looking at what are these other factors and how can we work with them. So this is, I think, a really interesting case. This was a study of dengue and chikungunya spread by the same mosquito done at the border of the US and Mexico. And what you see is, obviously, these places do not have differences in climate, vegetation. They're very much in the same place, but the living conditions are dramatically different. So you see a 4% infection rate in Brownsville, Texas, and a 32% infection rate just across the border in Mexico. And here, some of these factors are that 85% of the homes in Brownsville are air-conditioned and only 29% across the border. There are bigger lots in Texas, so you're not as crowded together. And that's part of what we're seeing in Puerto Rico, that we're seeing infection rates that are close to what you would expect in that kind of an environment. So this is a map of air travel, and this is where I come back to our global health security agenda. The CDC is part of a government-wide effort to improve global health security across the world because of the connection that we have with the rest of the world, that we're all connected by the air we breathe, by the environments that we live in, and by our human connections through all of the travel and trade that goes on across the world. So the effort that sort of underlies these outbreaks that we see is to bring other countries' capacity to detect, respond, and prevent diseases around the world, to strengthen that globally. And that will help us, that would help. Ebola was a really stunning example of how an outbreak in one part of the world can affect the global health and the global economy. So this has been a major effort and is part of the ongoing public health capacity building that we're doing following on the Ebola outbreak. So just to show you some maps of spread, this is dengue, spread by the same mosquito as Zika. This is the spread. From 1950 to 2013, this was the spread of chikungunya, and then that came to the Western Hemisphere in 2013 to 2015. So this is, Zika moving is part of this trend as well. And you can see that these are fairly similar patterns. So I just want to quickly talk about Puerto Rico, where we have seen these outbreaks as the kind of the bellwether for the U.S. So this is chikungunya in 2014, and that was a week-by-week map. It shows you the spread. And this was the final map for chikungunya. This is what we're seeing now in Puerto Rico from November through April. That top line is Zika. The other lines are dengue and chikungunya, and you can see the dramatic increase there in the third or fourth week of the year. And this is what Puerto Rico looks like today. with over 600 locally acquired infections. Their labs have done over 6,000 tests. They know they have at least 65 pregnant women with Zika. And that has been the real focus of our work with Puerto Rico. So the lab obviously needed a lot of support. We have a lab in Puerto Rico that works on dengue, and so we've been able to partner with them very effectively. We are also doing surveillance of pregnant women and newborns to understand what the risks are longer term. I'm going to talk about. So here's the map of the Aedes aegypti, and Aedes albopictus, which we also have some concern about transmission, but it seems to be a less competent vector. What I want to say about this map is this is the best data that we have. A lot of it is based on models and other things that scientists have done. We don't have really strong vector surveillance. Public health people are weird. We like to go out and count mosquitoes. So we are hoping that one of the things that we can do through this response is really improve our vector surveillance in this country, which helps us target the control efforts. As Ron explained, this is a really challenging mosquito. I've heard people call it the cockroach of mosquitoes. And so we have to do many, many things to try and control it. There's not one specific intervention that does the job. And so, for example, in Puerto Rico, those efforts are focused on the homes of pregnant women. Very, very targeted, because it's not something that is effective if you try and do it community-wide. Ron was surprised to hear we have over 400 travel-related and sexually transmitted cases in the continental U.S. right now. We are working with state health departments to monitor those and to provide clinical guidance for, particularly for pregnant women. So I'm going to get to the funding request in my last few minutes. The administration has asked Congress for $1.9 billion in emergency funding. 1.5 of that is for the Department of Health and Human Services, and I'll speak specifically to what CDC has requested. You've kind of heard me talk about throughout this some of the work that we're doing. We really need to dramatically expand, and we need to do it before mosquito season hits the continental United States. So we are already working with some funding that we've repurposed to work with all of the states, particularly those that appeared on the map and have the mosquito. We know we've seen limited outbreaks of dengue and chikungunya in the United States, and we don't think we will have explosive outbreaks like Puerto Rico or Brazil. But we need to be vigilant about that, and we need to continue to support Puerto Rico. We also really need to learn more. And so some of the things that we would like to get started on as soon as possible are some of those longer-term studies to see if we follow babies born to women who were exposed to Zika, what are some of the effects? What are some of the factors that were protective or risky for those women? What are some innovative methods for controlling mosquitoes, and what are some better diagnostics that we could introduce? And you can see some of the other activities here. So that's an overview, and I suppose we'll have questions with the panel. Thank you.
Before we begin our panel discussion, we'd like to hear from Alan Brecka from Tulane. Alan.
Hi, I'm Alan Brecka, and I work on thinking about ways for us to mitigate the health costs of climate change. So today I'm going to share some lessons I've gleaned from my research on malaria, which is a disease that's also transmitted by mosquitoes. We're going to learn three things, and we're going to see how we could apply those lessons to fighting Zika today. So I want to start in a non-fictional setting, and I'll tell you more about this location later, where you have a 1 in 10,000 chance from dying from malaria, which is caused by the Anopheles mosquito, which is different than the cause of the malaria parasite. You have a 1 in 10,000 chance of dying in this place. You also have a 1 in 50 chance of contracting the malaria, and brings on serious fevers and chills, which is very very challenging for you to make it to get to work or go to school, for that matter. And as I find in my research, if you just happen to be a child who's born in a particularly bad epidemic year where there's high malaria rates, you go on in your lifetime, possibly through developmental delays in early childhood, you go on to have a 10% less likely chance of finishing 8th grade or high school, or a 10% higher chance of ending up in poverty. So this is not the case for the United States today. We have, throughout the world, there are some 200 million cases of malaria every year, 500,000 deaths. These are our best guesses, but yet virtually no chance of contracting malaria in the United States. So what can we learn from our experience with malaria? And I should say that this fictional setting that I'm taking you to, I kind of jumped a little bit ahead, is that we're going to look at malaria actually in the United States. So the U.S. actually, in the 1920s and 1930s, malaria was a serious problem. So what are we going to be able to learn from our experience? So I've got a map for you of the malaria death rate. Malaria cases were really hard to record in the early 20th century. But what this map is showing is that the places like Louisiana, the Florida Panhandle, Mississippi Delta were the places where the malaria was the most prevalent. So these were 10 times higher, say, than in Virginia. So the South, malaria was a Southern problem, okay? And note that also, following up on Janet's point, that the South is also poorer. So if we're thinking about Zika, this is also going to be the case, where we're going to see the poorer parts of the U.S. are going to be most affected. But there's also another important lesson for our talk today, given our focus on climate change, and that is the South is, shocking revelation, warmer than the rest of the U.S. So I'm from New Orleans, and I can definitely preach to that. So laboratory experiments suggest that the malaria parasites, these mosquito populations, thrive when the temperatures are in their 70s and 80s. So it's got to be nice and warm. These are from laboratory experiments. What does this mean then for us in the future? Well, as Ron noted, that we're going to see this distributional shift in temperatures in the U.S. So we're going to end up with more temperatures in the extreme, so more warm temperatures. To put this into a nice, simple statistic, the climate change models predict something like 60 more days above 80 degrees Fahrenheit. So this is right in that range that at least the Anopheles mosquito really like. In the studies I've seen on the Aedes aegypti, they also suggest that those temperatures are ideal. So that's suggesting that we're going to see increased risk of mosquito-borne illnesses in the U.S. So more risk in the South, potentially throughout larger parts of the year, but also those risks moving north. Okay, so what can be done? A little bit of hope here. Malaria is not a problem anymore for the United States. So what happened over time? So in the 1930s, the malaria death rate was about 10 per 100,000. That's about the same level we have for deaths from motor vehicle accidents. So this is relatively high. So 10 in 100,000, that would be like one student at Tulane University, where I teach, dying every year from malaria. So that's a real number. But they think that the infection rate was something like 200 times higher than that. So in the 1930s, malaria transmission in the United States was relatively stable. But then there was this big drop between 1935 and 1940. So what happened? What gives? Well, there are a few things. The first two we have pretty good evidence on. The first being that the New Deal allocated considerable amount of money to draining ponds, constructing better drainage along ditches. Something like tens of thousands of ponds were drained, and thousands of miles of ditches were also better drained. So this is the first thing that we think led to this drastic decline between 1935 and 1940. The second thing we think is that populations were moving out of rural areas in the United States where the contact between humans and mosquito was relatively frequent. So when you take people and you take mosquitoes and you separate them, you break the cycle of the disease. So as part of the New Deal, they paid farmers to fallow their land, and this led from a transition away from sharecropping, where we had large numbers of farmers with relatively small plots of land who ended up having to leave because there was no need for their labor anymore. So they moved to urban places, or they ended up moving north. So that helped break some of the cycle. The third thing I want to mention is that where we don't have as much evidence for is that education was increasing over this time period. Now, it can't necessarily account for this stark decline between 1935 and 1940, but it wasn't really until 1900 where people actually knew the malaria parasite was caused by the mosquito. They used to think it was just caused by bad air, mal-area. So at the early 20th century, people didn't quite have the grasp of where this was coming from. And I think there might be some lesson here about how we can use education to hopefully, reduce the prevalence of Zika. And I also want to point out that the CDC came into being around, 1946, So we began spraying for these mosquitoes starting around that time after World War II, because we needed to conserve our spray, that DDT chemical, that very powerful chemical, until then. So it wasn't the spraying that necessarily caused this massive decline. So old school technologies ended up having a pretty sizable effect on a mosquito-borne disease in the United States. So to recap, key three things I would like just to leave you with is that, one, southern states are more at risk. These are the poorer places, and we expect that children, especially in these places, to be more vulnerable. Climate change is likely to increase these risks. So we saw about 60 additional days in these really hot temperatures, these days above 80 degrees Fahrenheit. And we've got some old school policy tools. Now, I don't want to say that these are the magic bullet to solve the Zika problem. I only wish to just say, in addition to thinking about insecticide-treated bed nets, in addition to thinking about spraying with powerful insecticides, that there were some effective tools from the past that we can draw on. And in my pun moment of the evening when I was preparing this, we could think about another DDT. We could think about drainage. We could think about economic development, possibly drawing people in from the subsistence farming into the urban environments. And then we could also think about teaching and educating people about the ultimate cause of Zika. And the final thing I want to leave you with is a quote by the Dalai Lama. If you think you are too small to make a difference, try sleeping with a mosquito. So, thank you.